Welcome back to the Deep Dive. We are shifting gears a bit today. Usually when we talk about nutrition or, diet, the conversation lands somewhere between, I don't know, cultural trends and weight loss hacks.
Right, the latest superfood or something?
Exactly. But today, I want to transport us into a much, much higher stakes environment. I want you to just picture a patient in the ICU.
Okay.
They're sedated, ventilated, lines running everywhere. To the naked eye, they look perfectly still. But inside there is a metabolic war raging.
That is the perfect way to frame it. It is a war. And the casualty count in that war, well, it's measured in things like nitrogen balance and visceral proteins.
Yeah.
We're looking at nutrition evaluation and support, but really what we're looking at is the biochemistry of survival.
And this is where the literature we're covering today gets so fascinating. We are not talking about the food pyramid.
Not at all.
We are diving deep into the clinical mechanics of keeping a human machine running when the intake valve, the mouth, is basically welded shut.
And it's strange because even in modern medicine, nutrition can sometimes feel like an afterthought.
Right. We obsess over the blood pressure, the oxygen saturation, the antibiotics, but the fuel. We just sort of assume the body will figure it out on its own.
Which is such a dangerous assumption. The source material makes it crystal clear. Malnutrition in a hospital setting isn't just about hunger, it's a systemic failure.
A systemic failure.
How so? It's a breakdown of the body's ability to use energy, to absorb nutrients, or even to process protein. So if you ignore it, you're not just letting the patient lose a few pounds.
You're doing more damage.
You are letting their cellular structure degrade. It increases mortality, it tanks the immune system, and it can turn a recoverable illness into a terminal one.
So, okay, let's treat this like the vital sign it is. The sources, they lay out this roadmap that medical professionals use. And it's almost like they're acting as nutrition detectives.
That's a great way to put it.
We have to screen, then assess, then calculate the fuel mix, and then finally figure out the delivery method. Let's start with that detective work. Chapter 59 makes this really hard distinction between screening and assessment. Now, I've seen these terms used interchangeably, in meetings, but clinically, they're different beasts, aren't they?
Oh, completely different. Think of screening as the dragnet.
It's a dragnet.
It has to be quick, it has to be cheap, and it has to be applicable to every single person who comes through the door. When you walk into a hospital, the screening is that initial filter.
And who does that?
Usually a nurse within the first 24 hours. Their job is just to flag risk. It's a simple pass-fail system.
Okay, so it's like the metal detector at the airport. It just beeps. It doesn't tell you what is in the pocket, just that something is there.
Precisely. That's the perfect analogy. It just catches the outlier. The assessment, then, is the pat-down.
Okay.
That's the deep investigation. If the screen beeps, the dietitian comes in for the assessment to diagnose the specific type of malnutrition and then build a plan.
And this is where we run into our first major hurdle, which is the patient's history, which is notoriously unreliable. You ask, how much do you weigh?
Yeah.
And they say, oh, about 180.
But they haven't stepped on a scale since, the 90s.
Right.
But we have to work with what we've got. And the one big red flag the literature really points to is specific. Unintentional weight loss.
Unintentional, okay.
If a patient has lost more than 10% of their usual body weight in the last 6 months, that is a massive alarm bell.
10%.
Yeah.
It doesn't sound like a lot until you actually do the math. If I'm a 200-pound guy, that's 20 pounds.
Yeah.
Just vanishing.
Yeah.
Without me trying. That implies a catabolic state, doesn't it?
Yeah.
The body is literally eating itself.
It implies that the metabolic demand has outstripped the intake for a long, long time, and it correlates directly with poor clinical outcomes.
And it's not just weight.
No, we also look at what's called functional capacity. It's not just did you lose weight, it's can you still walk up the stairs? Is your grip strength gone?
So the real-world impact.
Exactly. We are looking for the physical manifestation of that fuel shortage.
This brings us to anthropometrics, measuring the machine. The sources list the classics: weight, height, BMI. But in that ICU scenario we started with, getting an accurate weight seems like a logistical nightmare.
It is a nightmare.
You can't just ask a comatose patient to, hop on the scale.
Right. We often have to rely on dead scales, which are notoriously finicky, or reported weights from family members. But even if we get the number itself can be a liar.
How so?
We have to distinguish between actual body weight, ideal body weight, and usual body weight. And then there's the great masquerader, fluid.
Let's talk about that, because in something like heart failure or kidney failure, a patient just swells up.
Exactly. So let's say we have a patient, Mr. Miller. He comes in with heart failure. He weighs 85 kilograms.
Okay.
But 10 kilograms of that might be pure water retention edema. If we calculate his nutrition needs based on 85 kilos, or if we just look at that weight and say, oh, he's well-nourished, look at him, we're missing the fact that underneath all that water, his muscle mass is wasted away.
So he's starving, but he looks swollen.
He is essentially a skeleton in a water suit, and that's why the text warns us again and again about interpreting weight in fluid-overloaded patients.
It's a disguise.
A very effective one.
The text also mentions BIA, bioelectrical impedance analysis. That's where you send a current through the body to distinguish fat from muscle. I've seen this on those high-end bathroom scales. But does that actually work on our Mr. Miller in the ICU?
In a healthy person at the gym, sure, it's decent. In Mr. Miller, absolutely not.
Why not?
BIA relies on the conductivity of water to estimate lean tissue. If Mr. Miller's fluid balance is chaotic, if he has edema in his legs or fluid in his lungs, the electrical signal just gets distorted.
So it's garbage in, garbage out.
The machine will give you a garbage reading. So while these high-tech tools exist, the clinical eyeball and just tracking trends over time often beat the gadgets.
It seems like pediatrics is really the only place where the metrics are straightforward.
Yeah.
The growth chart is king.
It is the ultimate report card. If a child falls off their growth curve, it is an immediate crisis. The velocity of growth, how many grams per day a newborn gains, is a direct readout of nutritional adequacy.
And what are those numbers?
Newborns need to gain about 10 to 20 grams per kilo per day. If they don't, you are actively stunting potential brain development. The stakes are just incredibly immediate.
Okay, so let's move from the outside measurements to the inside.
Yeah.
The biochemistry, the lab work. I think there's a common misconception that we can just draw some blood and see a hunger level. But the sources highlight these things called visceral proteins, albumin, prealbumin, transferrin. I want to challenge the use of albumin specifically. It's the standard, right? Every doctor orders it.
They do, and often it's just out of habit. But albumin is a terrible marker for acute nutrition. It has a half-life of 18 to 20 days.
So nearly 3 weeks. That means the albumin level I'm looking at today reflects the nutrition Mr. Miller had 3 weeks ago.
Effectively, yes. It's extremely slow to degrade. If Mr. Miller stops eating today, his albumin might stay totally normal for 2 weeks.
So it's useless for what's happening now.
It's like reading a newspaper from the beginning of the month to check today's weather. It gives you long-term climate data, but it misses the storm that's happening right now.
So for the breaking news, we use prealbumin.
Right. Prealbumin turns over every 2 to 3 days. If you start feeding a patient, prealbumin goes up quickly. If they stop eating, it crashes. It's the Twitter feed of nutrition status.
Okay, that makes sense.
But, and there is always a but with these things, we have to talk about the stress confuser.
This was the part of the text that made me realize how incredibly hard this job is. You can have a patient who is perfectly fed, but their levels are still low.
Yes. In the presence of inflammation, so trauma, sepsis, surgery, the liver reprioritizes.
It has bigger fish to fry.
It stops making these transport proteins like albumin and prealbumin, and it switches to making what are called acute phase reactants to fight the infection.
So Mr. Miller could have a belly full of food, but because he has an infection, his albumin drops anyway.
Exactly.
So low numbers don't always mean feed me. Sometimes they just mean I'm sick.
Correct. You cannot interpret these labs in a vacuum. You have to look at the CRP, the other inflammation markers, and the whole clinical picture. It's all connected.
There was one other test mentioned that I found genuinely spooky, the link between starvation and the immune system.
Oh, yeah.
You talked about the recall antigen test.
This is just fascinating physiology. Malnutrition causes something called anergy. Basically, the immune system goes offline to save energy.
It just shuts down.
To test for this, we inject a tiny bit of something common under the skin like candida, which is yeast, or mumps antigen. Most adults have been exposed to these, so our immune system should recognize them and create a little red bump, a reaction.
It's the body saying, I know you, get out.
Exactly. But in a severely malnourished patient, you inject the antigen and nothing happens. The skin stays flat. The immune system is so depleted it can't even mount a recognition response. The spooky part, as you said, is that when you start feeding them properly, the response comes back. You are literally refueling the army.
That's incredible. Okay, so we've assessed Mr. Miller. We know he's malnourished. His proteins are a mess. He's catabolic. Now we have to write the prescription. And nutrition is a prescription here. We have to do the math. The source gives us a baseline. 20 to 25 kilocalories per kilogram per day.
That's the keep the lights on number for a non-stressed adult. So for a 70-kilo person, we're looking at roughly 1,500 to 1,750 calories.
Which is pretty standard. But the ICU is not standard.
Not at all.
This is where the stress multiplier comes in. I was looking at the varying requirements, fever, sepsis, trauma. They all ratchet up the burn rate. But the one that just stood out to me was burn victims.
Burns are the metabolic Everest. If you have a patient with large surface area burns, their metabolic rate doesn't just go up, it doubles.
It doubles.
At least. They aren't just maintaining tissue. They are trying to regrow an entire organ, their skin, while losing massive amounts of heat and fluid through the open wounds.
So while an elderly patient might need, say, 1 gram of protein per kilo, the burn patient needs what?
Up to 2.5 or even 3 grams per kilogram. For our 70-kilo man, that's over 200 grams of protein a day.
200 grams. To put that in perspective, a single chicken breast has maybe 30 grams.
Right.
So you're asking a critically ill patient to eat 7 chicken breasts a day.
It's impossible. And that's why we need high-tech support. It's the only way.
And we can't forget the water. The 1-for-1 rule seems easy enough, 1 millimole of fluid for every calorie. But how do we know if we've got it right? In a car, you check the dipstick. What do you do in a human?
You check the urine output. It is the most honest metric we have for hydration.
Okay, and what's the goal?
For an adult, we want to see about 40 to 50 milliliters per hour. If they are putting out that much clear urine, the engine is hydrated. If it drops to, say, 10 or 20 millimolus, they're either running dry or their kidneys are starting to shut down.
Okay, now we get to the section that I think is the most treacherous for any medical team. We have the food and we have the drugs. And we usually just assume they play nice together. But this drug-nutrient interaction section, it reads like a list of betrayals.
It is the area most likely to be overlooked. We tend to silo these things. The doctor orders the meds. The dietitian orders the food.
And they don't talk.
And inside the stomach, chemistry happens.
Let's look at phenytoin. The brand name is Dilantin. It's a seizure medication. If you give it with tube feeding, it just fails.
It binds to the proteins in the formula. The bioavailability drops sometimes by as much as 70%.
70%.
So you have a patient who is seizing, you give them the drug, but because you didn't turn off the tube feed, the drug never actually gets into their blood, and they keep seizing.
So the protocol is to hold the food.
Right. You have to stop the feed, usually about 2 hours before the dose, give the med, wait another 2 hours, then restart.
That's a 4-hour window where the patient gets no nutrition.
And if they take the drug twice a day, that's 8 hours of starvation. You have to account for that lost time by speeding up the feed for the rest of the day. It's a logistical headache.
It really is. But the one that truly shocked me, and I want to spend a minute here, is propofol.
Ah, yeah.
It's the standard sedative, Michael Jackson's drug. Milk of amnesia? I had no idea it was actually food.
It is a lipid emulsion. Propofol is not water soluble, so they have to dissolve it in oil, usually soybean oil. A 10% lipid emulsion, which means every single milliliter of propofol has 1.1 calories of pure fat.
Okay, let's do the napkin math on this because this is wild. Let's say Mr. Miller is big, he's fighting the ventilator, and he needs a high dose to stay sedated, maybe 20 or 30 milliliters an hour.
Let's say 25 milliliters an hour, just to keep the math easy.
Okay.
You run that for 24 hours, that is 600 milliliters of lipid solution.
And at 1.1 calories per ml.
That is 660 calories.
That's a Big Mac.
It is. It's a Big Mac and fries injected directly into his veins every single day. So if the dietitian calculates his needs at, say, 1,800 calories and starts a full tube feed on top of the propofol, suddenly he's getting almost 2,500 calories.
And since it's all fat,
you risk something called fat overload syndrome. You can get high triglycerides, pancreatitis, liver damage. The team has to subtract the propofol calories from the nutrition plan.
It's a classic example of why the pharmacist and the dietitian need to be best friends.
They absolutely do.
And then there's warfarin, the blood thinner, fighting with vitamin K. It's not just in salads, it's in the formulas too. It just highlights that food is really just a collection of bioactive chemicals.
Exactly.
So we have the plan. We've avoided the drug clashes.
Yeah.
Now, how do we get it in? The outline splits this into two worlds. Enteral, which is using the gut, and parenteral, using the vein. And there's this mantra in the field, if the gut works, use it. Why are we so obsessed with the gut? If I'm in the ICU, just give me the IV. It seems cleaner, easier, no risk of vomiting.
It does seem cleaner, but biologically, the gut is a use it or lose it organ. If you stop putting nutrients into the lumen of the intestine, those little finger-like absorbers, they shrink and atrophy.
They just waste away.
Yes, but worse than that, the gut is a major immunological barrier.
It keeps the bad stuff out.
Right. It keeps the bacteria that live in your gut. If the gut wall breaks down from disuse, those bacteria can migrate through the wall and into the bloodstream.
Oh, wow.
It's called bacterial translocation. So by trying to be clean with an IV, you might actually cause sepsis originating from the patient's own empty stomach.
That is a horrifying image. So we use the gut just to keep that barrier strong.
Correct. Even if we can only trickle in a tiny amount, what we call trophic feeding, it helps maintain that integrity. It's incredibly important.
So we're going with tubes. Short term, we go through the nose, nasogastric or NG.
Yep.
But I've heard about the risk of aspiration. If Mr. Miller is lying flat on his back, isn't there a risk the food comes back up and goes into his lungs?
Huge risk. And that causes aspiration pneumonia, which can be fatal. If a patient has a lazy stomach gastroparesis or is at high risk for reflux, we bypass the stomach entirely.
You go further down.
We thread the tube past the stomach and into the small intestine, into the jejunum.
The nasojejunal tube.
Right. You can't vomit what isn't in your stomach. It's a safety valve.
And once that tube is in, we have delivery options. Bolus versus continuous. Bolus is like a meal, right? You just dump a can in and wait.
Yes, but imagine someone pouring a liter of Ensure into your stomach in 5 minutes.
I'd feel sick.
You'd have distension, cramping, and maybe something called dumping syndrome, where the rapid sugar load causes diarrhea and dizziness. Bolus is great for rehab patients who want freedom to walk around, but for our ICU patient, Mr. Miller, no way.
So for him, it's continuous.
We use continuous feeding. A pump drips it in slowly, 50 or 60 millimoles an hour. 2047 is much more gentle.
But even with the pump, things go wrong. The troubleshooting section mentions clogged tubes. It sounds so mundane, like a clogged drain at home. But in a hospital, it's a crisis.
It is.
If the tube clogs, you might have to pull it out and reinsert it, which is traumatic for the patient.
And costly. And the main culprit is usually medication. Nurses crush pills to put them down the tube. But if they aren't crushed fine enough, or if they mix with the formula and turn into, well, cement, game over.
I have to ask about the Coke myth. I've heard nurses swear by using Coca-Cola to unclog feeding tubes. Does that work?
The logic is that the acid in the soda eats the clog, but the data doesn't really support it. In fact, the acid can actually denature the proteins in the formula residue and make the clog worse.
So you turn the clog into cheese, basically.
You pretty much do. The scientific fix is a mixture of pancreatic enzymes like creon and sodium bicarbonate. You create a little digestive cocktail, you inject it into the tube, let it sit, and it digests the clog chemically.
Science over soda.
Much safer than soda.
Got it. Okay, now, sometimes, despite our best efforts, the gut is just broken. Maybe there's a blockage, a fistula, severe ischemia, the no entry sign is up. So we have to bypass the system and go straight to the blood. Parenteral nutrition. PN. This feels like sci-fi to me. We are literally building blood from scratch.
It is one of the great medical miracles of the 20th century, total parenteral nutrition, or TPN, but it carries very high risks. And first, you need a big vein.
The text differentiates between PPN peripheral and CPN, which is central. PPN is just a regular arm IV, right?
Yes, but you're very limited. Veins in your arm are small and fragile. If you pump in a thick, concentrated nutrient solution, which is hypertonic, it strips water out of the vein cells and causes inflammation, or phlebitis.
The vein collapses.
The vein literally collapses. So PPN has to be watered down. You can't fit many calories in it. It's a bridge for a few days maybe, but it's not a long-term solution.
So for the real deal, you need a central line.
You need a catheter tip sitting in the superior vena cava right above the heart. The blood flow there is massive liters per minute. You drip the concentrated food in and it gets diluted instantly so it doesn't damage the vessel walls.
And the food itself, it's not just blended steak in a bag. It's elemental.
It's the raw materials. Carbohydrates become dextrose, proteins become crystalline amino acids, and fats become those lipid emulsions we talked about with propofol.
I noticed a little detail on the dextrose. In food, a gram of carbs is 4 calories. In the IV bag, it's listed as 3.4 calories. Why the discount?
It's because of hydration. The dextrose molecule that's used in IV solutions is attached to water molecules. It's dextrose monohydrase, so you get slightly less sugar per gram of weight. It's a nuance, but when you're calculating for a burn victim who needs 4,000 calories, Those little decimals add up.
And we have to talk about the fats again, the lipids. Because if you leave them out, bad things happen.
Oh, yes. In the early days of TPN, they sometimes forgot the fat, and patients developed essential fatty acid deficiency.
What does that look like?
Their skin would get scaly and dry, a specific kind of dermatitis. They'd lose their hair, their wounds wouldn't heal. We learn you must provide lipids not just for calories, but for basic cellular structure.
Okay, we are near the end, but we absolutely have to cover the most dangerous phenomenon in this entire field, refeeding syndrome. The name sounds so counterintuitive. Refeeding sounds like a good thing. Why is it deadly?
This is the paradox of starvation. Let's go back to the survivor of a famine or even a chronic alcoholic who hasn't eaten in weeks. Their body has adapted to starvation. It's running on fumes, fat stores, ketones. Their insulin levels are incredibly low.
The factory is shut down.
The factory is shut down. Then, well-meaning doctors hook them up to TPN and flood the system with dextrose sugar. The pancreas wakes up and screams, "Sugar!" and it dumps massive amounts of insulin into the blood.
And insulin's job is to open the cells to let sugar in.
Yes, but insulin is a bully. It doesn't just push sugar into the cells, it pushes electrolytes in too, specifically phosphorus, potassium, and magnesium.
So it drags them along for the ride.
They get pulled out of the bloodstream and shoved into the cells to help metabolize all that sugar.
So the blood levels of, say, phosphorus just plummets.
They crash. You get profound hypophosphatemia. And here's the mechanism of why that's so deadly. Phosphorus is the P in ATP, adenosine triphosphate.
The energy coin of the body.
It's the energy currency. If your blood phosphorus drops too low, you cannot make ATP.
And the muscle that needs ATP every single second is?
The heart. And the diaphragm, so you can breathe. The patient goes into acute heart failure or respiratory failure. They can die of cardiac arrest because you fed them too fast.
That is just terrifying. You try to save them with food, and the food is what stops their heart.
That's why the mantra is start low, go slow. You might start at only 25% of their calorie goal and inch it up over 4 or 5 days, all while checking their electrolytes every 6 to 12 hours. It is an absolute tightrope walk.
This entire conversation has just completely shifted my perspective. We started by saying nutrition is a vital sign, but it feels much more like high-stakes chemistry.
It really is.
We're managing pH, electrolyte shifts, drug interactions, immune responses, all through a little plastic tube.
It's a multidisciplinary science. It requires the nurse watching the pump, the pharmacist checking the lipids, the doctor managing the fluid, and the dietitian calculating all the math. When it works, it saves lives that would otherwise just wither away.
It really blurs the line between what's natural and what's clinical. I keep thinking about the propofol calories and the warfarin vitamin K war. We think of drugs as the powerful synthetic stuff and food as the simple fuel. But in the body, it's all just molecules interacting.
Absolutely. A nutrient is just a chemical that we happen to need. In high doses or in the wrong context, it acts just like a drug with side effects and toxicities. Food as medicine isn't a metaphor here.
It's literal.
It's a literal description of what's in that IV bag.
That is a perfect place to land. Next time you feel hungry or you see a hospital drama where they just casually hang a bag of fluids, remember the complex negotiation that's happening at the cellular level. Mr. Miller is fighting a war, and nutrition is the supply line.
Well said.
Thanks for listening to this deep dive. Stay curious, stay fed, and we'll catch you on the next one.